Thank you, John. Good afternoon, everyone. We're going to wait a couple of minutes to let a few more people join, and then we'll get started. We want to respect everyone's time, so we'll go ahead and get started. Welcome, everyone, to the Department of Geriatric Medicine monthly grand rounds. Before I introduce our speakers, we have a few logistics to go through. This CME activity is sponsored by the Hawaii Consortium for Continuing Medical Education, which is a joint venture between the Hawaii Medical Association and the John A. Burns School of Medicine, University of Hawaii. At this time, please enter the name and credentials of everyone viewing grand rounds for CME attendance purposes. As a reminder, evaluations are required for CMEs. You will be able to do the evaluation by following the link in the chat or at any time on our website and also on the email advertisement. Your comments are very important to the planning committee and will be used to plan future programs. As you know, all sponsors of CME are required to execute a conflict of interest policy. Dr. Lubimir and Dr. Takenaka have disclosed that they have no relationships with commercial supporters that could be perceived as a conflict of interest in the context of this presentation. It is my great pleasure to introduce our two speakers today. Both Dr. Lubimir and Dr. Takenaka are assistant professors in the Department of Geriatric Medicine, John A. Burns School of Medicine. Both are clinician educators who completed geriatric medicine fellowship training at the Department of Geriatric Medicine, and also both completed a master's degree in clinical research at the John A. Burns School of Medicine. Dr. Lubermair has an interest in health literacy as it impacts health outcomes in culturally diverse elderly populations. She graduated from both the University of Connecticut Schools of Dentistry and Medicine. She currently serves as the clerkship director for the required geriatric and palliative medicine rotation for fourth-year medical students, and her clinical practice is providing home-based primary care and geriatric consultations at the VA Pacific Islands healthcare system in Honolulu. Dr. Takenaka's interest is in nursing home care, medical directorship, and quality improvement. She graduated from the John A. Burns School of Medicine. She currently serves as the Associate Program Director for the Geriatric Medicine Fellowship at UH, and her clinical practice is in the Queen's University Medical Group's post-acute and long-term care services. She also serves as Associate Medical Director at Avalon Nursing Home. Please join me in welcoming both Dr. Lubimir and Dr. Takenaka. They did wish me to give an acknowledgement to Dr. Winona Lee of the Department of Native Hawaiian Health, who provided funding for both of them through the CARES Act to work on telemedicine curriculum that has helped with this presentation. Dr. Lubimir and Dr. Takenaka, please go ahead.
Thank you. Okay, I think I'm in charge of this slide. So it's so interesting, we're talking about technology and I always need a refresher on Zoom. So thank you for joining us today. Dr. Takenaka and I are going to talk about telemedicine and teaching, making it happen. It's really two parts, and I will be talking more about the logistics, organizing the appointment, getting your learners ready, and then the real life experiences are going to happen when Dr. Takenaka talks about bringing that into long-term care setting. So let's get going. If I have control, there we go. Oops, sorry, I went too far. So our learning objectives today, we'd like the preceptors to be able to identify methods to prepare the learner for telemedicine encounters. Secondly, to list important steps to prepare the patient for learner-led telemedicine visits. Also then to describe strategies for teaching during a clinical encounter, and then how to facilitate the post-encounter experience for trainees. So telemedicine, it's a broad term. It actually encompasses telehealth, also phone visits or virtual visits. So I would suggest that many of you have either participated, run, been the recipient of telemedicine already. So even though it seems a little unfamiliar because of the pandemic, actually, if you've ever called a patient in follow-up or a caregiver in follow-up, you've participated in telemedicine, or if you've been the recipient of lab tests or other studies, but that interaction would constitute telemedicine. I would just say, I'm not going to talk too much about telemedicine, the breadth of it, but just know it's here to stay. It's been shown now that we've really been at it since March of 2020. It's here to stay. It's improved access to care. It helps with workforce shortages, and it's been shown to improve chronic disease management and health outcomes. Also, there's a high percentage of patients who enjoy it, as well as practice settings that are planned to continue even after this pandemic leaves us. There's a high level of patient satisfaction, and CMS and other insurers are currently paying for these services. So what happened? Well, if you look down here in orienting you to, this is percentage on the y-axis, and then the months by 2020 into 2021, what happened with telehealth usage? So way down here, less than 0.01% were actually garnered in this survey looking at telemedicine. And then, right, March happened, right, in 2020, and it really peaked at that point. But even as we go through these months where we had the vaccine and people were more likely to resume in-person visits, it's actually stabilized to about 38 times what it was pre-pandemic. What practice settings are currently using telemedicine? This is again from McKinsey. They do COVID-19 surveys, and they looked at what change or what transition. Again, if you look at their time frame, it looked as of June 14, 2021. Again, when we just last summer, when people had been vaccinated, had multiple vaccines already, or completed their series. So if you look, still telephone responses are low. Except in, if we go down to mental health use of telemedicine has actually exploded, a whole nother topic. And then telemedicine, like virtual visits, has also kept up with that. Other areas, not so much, less than 20%, although a pharmacy or retail store may be at about 0.25%, pediatrician, about 0.25% of their practices. But again, we're sort of back into face-to-face. Again, this was June 2021. I don't have other information. Another thing that happened was Oregon Health Sciences University looked at who was using telemedicine, and they compared from 2019, January through September of 2019, through with January through September of 2020. And what did they find? Who's using telemedicine? And they had some interesting findings, and that's that it's mostly non-Hispanic whites, individuals that were using telemedicine as patients. Who was lost? Medicare, Medicaid persons, people over 65, those considered to be indigenous or descent, or those who English was not their preferred language. Those persons actually rather would, instead of virtual visit, preferred telephone visits. And the outcome of that study said we cannot forget those people that may be left behind in this era of telemedicine. This is a huge industry. There's projections of $140 billion industry by 2025, and that's starting at maybe 30 billion. You can't open your email now without getting assaulted almost with how many opportunities there are to turn telemedicine around. Or do you want to be a telemedicine provider across the straight lines? You know, you can provide telemedicine as a provider. So again, this is here to stay. So why are we talking about this in academic medicine? Well, medical students. Actually, in 2015 and 2016, pre-pandemic, right, the AAMC began to look at telehealth and curriculum and looking at the future of medicine. And they found that about 25% of all schools had telemedicine, the majority of that being in the clinical years. And it was this issue, they said, we need to have competencies in this area. And it was really pushed to the forefront with the age of the pandemic. And we really want students to graduate with a set of skills. They need to appreciate patient safety, appropriate use of telemedicine. These competencies also include access and equity in telehealth, communication via telehealth. They need to be able to collect data and assess during a telehealth visit. They need to understand the technology, which with our millennials is not so much of a problem, right? And also then the ethical practices and what are the legal requirements for providing medical care via telehealth. As far as our resident physicians, the only milestone I could find out of ACGME was in 2021, published for internal medicine residents. I did not find the same for family medicine, nor our geriatric medicine fellowship trainees, although I think this is coming in my review of the literature. So you can see what some of the milestones are for digital health and the levels that we'd like them to achieve. So I'm going to go into 4 areas of precepting in the era of telemedicine. And we're going to look at structure and policies, preparing the learners and the patients for telemedicine visits. How does it flow? What does the workflow look like? How do the visits flow? What are your roles? What are the patients and the learners' roles in that? And then finally closing the loop, or the debriefing, having this closing the loop on for the patient as well as for the learner from that experience. So we're going to walk through these. So under structure and policies, the platform for visits. This is the technology. You're going to need to introduce the technology, whatever your health system is using. Again, we know that there are many platforms out there. Some of the problems maybe with connectivity, if they're not on site providing that care, issues with broadband service, if the student is accessing it off site. What are the organization or the health system's organization specific policies? Are there trainings that need to be completed by the students before they start? And they have to make sure that they're using HIPAA compliant, compatible devices for the visits. Make sure that everything is downloaded and that the trainee has access. Very helpful to have that IT help desk number before the day starts, when they're trying this technology out right on hand. You and they should be very familiar with the features of the system that you're using. Remember again, the millennials that are our medical students now, and just the early generation Z is also starting in medical school. They grew up with technology. So they actually, and they like a collaborative environment. So you may invite them to share what do they know about the platform, or what, intricacies have they found about the platform, and they really embellish the visits for you. I would also suggest a trial run before they start have their first visit. So work out any of those kinks. Continuing in structures and policies, make sure you have a sideline for the learner and preceptor to communicate. Very, very important. Instant messaging, again, maybe through the system, the health system or EHR that you have already. It can be a chat. You can use a phone line if using mute, but you need a way to communicate during the visit, because it really is, might need to address, oh, they didn't go into depth enough here, or their time is running out in the appointment, but there'll be a number of different things that you want to have in real time feedback for them. Make sure that you review or have them review telemedicine etiquette and communication skills. Very important. It's not the same as all of you who tried this or been a recipient or preceptor for or trying to deliver care. It's just not the same. And especially in our geriatric population or in a site, as Dr. Takenaka is going to talk about, in long-term care settings. First thing is, remember, they have to be in a HIPAA compliant location for the visit. If they're at home, it can't be a lot of things going on in the background. The patient has to have a secure environment. So the medical school may be able to provide something, or you may need to find an alternative site at the hospital setting. A couple different things to watch. There's telehealth best practices. I've included these resources, will be available to you at the end, but there's a best practices video, which actually came out of the Department of Health of the state of Hawaii, the section of genomics, produced this. Excellent, just an easy, quick video, but has some very practical points. The other one is Telepresence 5, and this came out of Stanford University, the School of Medicine. It's Dr. Verghese, if any of you are familiar. He's really trying to promote humanism and human connection within visits. And then they made a video to take those principles and apply them to virtual visits. It's how to just make that connection when, it feels we're very far away right now. I'm not standing in front of the audience, and I can't have all your faces smiling or nodding or frowning at me right now, but we miss all of that. And this tries to combat that. So really important. Also, as an aside, if you do look at the Telepresence 5, there is actually CME attached to it. So that's something else for you to watch prior. Okay, let's talk a little about preparing learners and patients or their caregivers. So check in with your learner. In our geriatric clerkship, we have a standardized patient telemedicine practice case for our entering students, and some of them said, oh, I did only telemedicine, I've done it, at one clinic, that's all we did. Other people like, oh, I've never done a real visit. I've never been the one who ran the visit. So a host of different experiences. What's their comfort level? What challenges have they faced? What are some of their concerns, during what's going to happen during that visit? What do I do if, right? Those kinds of questions. I would also suggest discussing how you select patients for a telemedicine visit. Who gets a visit? Is it going to be a post-procedure follow-up visit? Are you going to be reporting lab results? A well child check-in or something? Is it every other visit? Those kinds of things, but discuss that. And then as you're looking at your selecting the patient for the visit, you're going to pre-select this. I suggest you do it actually with the student, because you're going to look at the complexity of the patient, what their chief complaints are, what you know about their demographics, and try to match that a little bit with what the student's skills are and some of their goals for the experience. So I just said that for you. And then decide, is it going to be a synchronous or asynchronous encounter? So synchronous would be a joint visit with the learner and preceptor. Some of you may have heard this. I borrowed this from the APEC conference that was in the fall. But a synchronous visit, kind of, it's very patient-centered. It's cohesive. Patient isn't repeating themselves. So when the preceptor goes back in and asks the same questions again, so they get to just say it one time. Also allows you as a preceptor to watch how the student is doing. You can model behavior, and then again, as I said, directly observe how the trainee is interviewing or conducting the visit. Also, the other thing that happens are consults or IDT based, which may be synchronous, and there'll be multiple team members there. or allowing the trainee to interview first. Think of telemedicine just like we do medical knowledge. They're building blocks to this. It's kind of getting the hang of technology and communicating, and how to run the visit, how to organize the visit. So gradual increase of responsibility, as if you're working with a student, especially on more than one occasion, but see what they're capable of, and then gradually increase their autonomy for the visits. Students, especially we have fourth-year medical students, they really appreciate the autonomy during that, and set clear goals that you want them to accomplish, and the goals would be for that visit with that patient, as well as you need to let them know about the time frame. How much time do they have? What should they do if they get in trouble? When should they ask for you to come in, perhaps? Continuing on and preparing the learner and the patient and caregiver, make sure you obtain permission from the patient or caregiver for the student to be part of the telemedicine visit. It's been suggested to allow this trainee actually to make a pitch to the patient or caregiver to begin the interview, saying that, I'm working with doctor or nurse practitioner so-and-so, and we're going to spend some time together to go into depth about, your concerns for today. And then that individual, the preceptor, will come and join us, and we'll have time to, explore that further, just so that the patient or caregiver understands how the visit's going to be structured, and that, yes, they are going to get to see the intended preceptor. The patient and caregiver preparation, and I know this happens in the long-term care setting. It also happens, or could happen, we've done it, I do home-based primary care. We try to have all the bottles, the blood pressure readings, everything in one place. So giving them a little bit of a checklist, like having their vitals taken that day, all their medications or their brown bag right there. I guess again, in long-term care, you're going to hear from Dr. Takenaka how that setup can work. Also, any blood pressure, weight logs, glucometer readings, that have those on site at your side when you get ready to start your visit. Outline a visit agenda. That's going to be multi-person involved. We're going to have the learner, preceptor. You'll have talked maybe a little pre-agenda setting, but also at this point, you're going to include the patient or ask them to include the patient, trying to elicit their concerns. What else? What other concerns? And then outline that we have X amount of time with which to accomplish this, and then negotiate, how that might look, what's most important for you or for us to accomplish today for you. Don't forget in this introducing the people that are in the room or on the call, and what their role will actually be. So that may be the person's end of the patient's end. If it's their caregiver, having the patient introduce them, what's the relationship there. Review the limitations of telemedicine. Asking permission, there's a consent that usually occurs at the beginning of the appointment or pre-appointment, but consenting again, and then reviewing that I'm not physically there. I'm relying on your daughter to help me, look at your lower extremity edema or whatever, or take your blood pressure this morning. So we're relying on that, and knowing that and explaining that if we need to, this may need to convert, that you need to come in to be seen. Another very important part is confirming the location of the individual and what the contact information is in case there's an emergency and you need to direct EMT to that site. Very important to establish. And then a suggestion, model one visit as a preceptor, especially if this is a new setting or a new situation, consult clinic, home-based primary care, long-term care setting, hospital. I mean, it's been used in a multiple sites, or a family meeting, but you as the preceptor, model one, show off your website manner, okay? So what about the workflow and the visits? So priming the learner, very important. Pre-huddle, case specifics, making that connection. When you walk into that exam room or wherever the setting is, that you have history with that individual usually. And so the case specifics, discussing not just the medical history, but include the psychosocial, because that's how you make that human connection there. Set ground rules with the learner. So having them save their conclusions, not giving advice before you've talked about the case together, and then also giving them an out that if they're being pressed for details or something, oh, I'd like to defer to discuss that with my attending. That's always an option for a trainee. And then how to handle difficult discussion, how to handle difficult situations that come up during a telemedicine visit. So somebody's demanding something that, can't be provided. Like, I want this lab test and this medication and this MRI and whatever it is. And especially if they're asking for specific, give them tools to use. In other words, get curious, not furious is kind of the rule. And that's asking them why, like digging a little deeper. What are their worries? What are their concerns? What would this test, medication, whatever do for them? And so you would open a door really to have a better understanding for them. Team-based visits. Oh, another thing under difficult situations I always think of is that sometimes when our trainees are asking questions, why are you asking me so many questions? The individual will ask, and for the trainee to take a minute and either and to define their role in this part of the telemedicine visit. I'm the data gatherer. I'm getting the information so that all the parts, so that we can, and doctors or whoever the other providers, healthcare providers, we can analyze that and then organize it and then come up with, a plan for you. So allowing that to diffuse that situation. On team-based visits, make sure you establish the roles and responsibilities, especially if you have somebody. So this is, you have different levels of training. We have the attending, we have the fellow, now we're going to have the pharmacy student, we're going to have the nursing student, who's doing what here. But establishing those ahead of time. And maybe, again, people take different parts of the history or take different parts of the visit. But clearly establish who's going to do what when. And introduce that also to the patient or caregiver. Oh, physical exam skills. Challenging, right? Involving the patient or caregiver. We've already talked maybe having vital signs all done previously, very, very helpful. A functional physical exam where we have, I'd say, oh, could you go get that red cup off the counter there? So we have to get up and walk over there. We get to do, you'd be very creative. And there are some tools. There's called the Telehealth 10, and it's a guide for patient-assisted virtual physical exam, and we've included that in our resources. There are actually several resources, but this is what I thought was particularly useful. Caravan Health also had put one out, but I can't find that link anymore, unfortunately, but there are more if you look at that. Understanding or instructing trainees that there are limits to technology. Do we need to convert this to a face-to-face, or is this an emergency situation where we need to have intervention to get to acute care setting? So having them recognize those signs. Just staying in the workflow. Okay, now here's the hard part, I think, a little challenging. How do we present the case? So it's going to depend, right? If it's a synchronous visit or asynchronous, but let's just say you're synchronous and it's going to be a bedside presentation, or you're going to step out. And that can happen also if you're having a synchronous. The trainee presents the case. Oh, I'm sorry, the asterisks, I should say up here, the two little asterisks refer to the SNAPS model, which is just one way for case presentation and for facilitating a case with a trainee. We've also included that for you as well. But the trainee in bedside will present the case. They would identify a problem list. And when they're making their assessment, that's where they invite the preceptor to add. And that allows for you as a preceptor to redirect perhaps, or refocus. And then making the plan together again, based on some of the conversation or agenda setting that we've already had with that individual, the patient or caregiver. What if the trainee says something wrong? Oh no. So what do we do? Well, it definitely, we need the preceptor to step in and refocus or redirect. And just to say that, may I step in here? Make sure you thank the trainee. Thank you, whoever. And I'd like to add here, and this keeps it, you're still a team, and it doesn't cause the patient to question that there's a team involved in their care. The other way to facilitate case presentations is you're going to step out, and that has happened many ways. Sometimes we put the patient in a waiting room. Again, depending on your technology, we mute. we take all of ourselves off screen, and we have our discussion outside of that. So that would be the trainee identifying the problem list, making an assessment, coming up with a differential diagnosis, and proposing a plan that then you can discuss, and then the preceptor would go back in and join the visit. If it was asynchronous, to confirm parts of the HPI or focus physical exam, and then move forward with the assessment and plan during that. Just continue on. And what about closing the visit? Allowing whichever trainee, to summarize the plan, making sure it's aligned with what matters, one of our 5 M's, with what the patient's biggest concerns were, what they've identified as a concern during the visit. Inviting the preceptor. They should ask you, do you have anything to add to this in case something was missed? That you can feel free. And then partnering, making sure that the trainee invites the patient or caregiver to partner on those next steps. We've talked about many things about your diabetes. Which steps do you feel that you could move forward on, or what would be your barriers to doing that? But inviting that. And as far as the patient or caregiver, making sure in that video visit or that visit that you've allowed time for questions. You can check on their receipt of information by having them use teachback method so that you can then correct anything. The other suggestion is to elicit any feedback on how to adjust or improve the next visit, video visit or telehealth visit, whichever, if it's phone visit, how might it be improved the next time? What about technical issues during visit? Now, I know Dr. Chong, one of our fellows, is not on the call, but I just want to give you A++. We were on a geriatric consult, and the patient was in Seattle, actually. And so we made our video connection. We established everything was all good. The nurses were on in one room, and I was on another room. He was on another, social work another room. It was beautiful. And then it just went like this. We lost our audio. We still had the patient. So what we did was we did the dial-in, and it was great. They could still do their activity and their physical exam and answer all the questions, and we could monitor what was going on, but we had several parts of technology going on. So we had the phone visit as well as the virtual video visit at the same time. Did a very beautiful job. I want to commend him. So and the other thing during with technology is managing distractions. So many of us now have 2 screens going at the same time, right? You can have the individual on one screen and you have the chart open on the next screen, but the recommendation is to look at the camera, not at the screen. And then definitely, if you're going to go over and look at the screen, instructing the student, tell them, I'm going to look at your chart now, and or I'm going to write that down, so my head is going to drop, things like that. So managing distractions so that the individual feels listened to during the appointment. If there's a poor connection, just as I said, Dr. Chong gets the A+. He's not here. We can tell him later with a poor connection. Also happens in home-based primary care. The nurse will be on site, and it's terrible broadband service and wherever they are out in Iroquois Point, and we have to convert. She keeps the video on, and I can talk by phone. So that works really, really well. And then just looking at workflow and having trainees during this time pandemic, don't forget that they have other skills. Learners have other skills outside of that visit that we want to encourage them, because they've done their visit time with that individual, but they can be following up on labs or following up with consultants or other interacting with IDT members to making sure things are happening for that individual or in another patient that they've seen on a previous day. Okay, I'm almost done. So closing the loop on the visit. So debriefing, how does that work? What's the best way for that? Well, the timing may be important. And again, depending on your day, if you only have a half day, if you're only having one patient together, whatever that looks like. But is it going to be immediate after the visit's over? Or is it going to be at the end of the day? Obviously, immediate takes, you have to have the time worked out. But you may need to address things, because if they're seeing other telehealth patients during the day or televisits during the day, you want to correct something so they can go on with that information. The end of the day is more of that processing, how it went overall, and if there was a theme or a medical knowledge deficit that you found that was recurring or that they found they struggled with, it allows a longer time for interaction. Making sure part of our accreditation in medical, especially for medical students, is self-reflection or evaluation, and then very important, the preceptor feedback. So there's a mantra of ask, tell, ask. One of the things, right? Asking what the trainee, what they thought they did well, what they struggled with. Then you can tell or teach them something, do you agree or disagree? What were some of your observations? You can give a 1-minute pearl, clinical pearl. Dr. Kasuya, thank you. When I see this, I always have to keep in the back of my mind a differential of, Z, whatever. And then asking, what is the trainee going to do to improve? What, can they demonstrate something? Is there some place that they need to go look up in more information, or do they need more practice at a certain skill? And then making sure that you discuss key findings in clinical reasoning. Again, that's the SNAP model, because you really want to probe why did they come up with that differential? How did they, how did they decide that this was the path to go down in the workup or treatment of this condition? And then lastly, they should identify a learning issue that came out of this discussion or the day. And you as a preceptor, please, arrange your follow-up discussion so that you can truly close that loop. The last slide I think I have is on documentation. Again, depending on the health system that you're involved with, there may be templates. Make sure that student trainees are familiar with using those different templates. Want to make sure, is there a post-visit summary that's going to be important, and instructions that either get electronically sent off to the patient or caregiver through the portal, or is it, snail mail or some other method that they will get these instructions to be, they're not walking out with a list from their appointment. What are the deadlines? Please give a time frame for completion of the documentation. And then don't forget your attestation from CMS criteria from 2019 is the current way to document. And then there may be some needed follow-up with a patient or caregiver, and the learner can be assigned to do this after your discussion. It could be a post-visit phone contact, or maybe you've scheduled a face-to-face visit or another video visit within a time frame. Then there's something that learners can also do, cohort management, which are things like, did the patient actually pick up their medication? Or a call is, how is the medication or the treatment working that's been suggested? Or were they able to obtain their tests or a consultant appointment that you've recommended? And I think, whoops, sorry. I'm going to give up control. And we're going to see how it works in the real world.
Let's see if I can advance the slide. Oh, here you go. Oh, John, how am I able to advance the slides on this? Oh, here you go. So for this part of the presentation, we're going to talk about actually how I was able to operationalize all of these things that we quickly brought together and built as a curriculum in response to the pandemic in the spring of last year, starting from March 2020, which is what my kids call the longest spring break ever. This is also the time where they were sent home from school for spring break, never to set foot in a classroom until this school year for their case. And on the Jabson side and on the fellowship side and for residents, we were really trying to build structure and curriculum to prepare our learners from the department side, especially, for the geriatric rotation and for our fellows' whole clinical curriculum in specific sites for infection control and safety. how to provide guidelines to teachers and faculty on how do we make this happen, and also to prepare the learners for what is expected of them, how to provide an orientation so that they all start off with at least some kind of baseline understanding of what this whole new mode of clinical practice is in terms of our different clinical sites. And how to get our faculty comfortable with it. And so while we ourselves were kind of like piloting things on our own, between this time where I had to convert most of my visits to telemedicine for multiple nursing home patients and sites, it was about 6 to 8 weeks. If I average around 20 visits a week, without the special in-person ones that I did after hours when my husband was able to watch the kids, it was around 1,360 when I look back at the whole almost a year and a half in telemedicine. It went by in a blur. I precepted several internal medicine residents, and this time period spanned across 3 classes of fellows. I didn't realize until I looked back, like, oh yeah, I did start with the previous classes, even their long-term care service. And the fellows rotate with us for their month-long nursing home rotations, but also for my practice, they follow their nursing home long-term care patients with visits every month throughout the whole year. So all 3 classes during that time frame got to do some telemedicine visits with me, which is nice. See if I can go back. So as Dr. Lubimir was talking about how to plan for teaching, it's good to prepare your own practice first, to kind of have infrastructure to start your visits before you bring the learner in, and to see, okay, what would work? Do I have a system in the place where I'm managing the patient? For my practice and our core faculty practice, it was preparing the nursing homes for telemedicine, which is necessary for infection control. As we wanted to minimize the amount of people and trainees who are going in and out of the different nursing homes, just so that there would be less exposure for the patients and also the nursing home staff that had to be there with close contact to the patients. We really worked hard to advocate for safety, infection control, and worked with all of our different sites on how to build up the capability for telemedicine in nursing homes all over the island. It was a really Herculean effort. I'm really thankful to our faculty and our department for supporting so many sites. There was education for the originating site staff. So originating is where the patient is because it's patient-centered. And so that meant, getting the staff geared up for what it means to do a telemedicine visit, how to train the nurse or whoever was going to be there assisting you with the visit on how to do a physical exam. What kind of supplies do you need to run a telemedicine visit? Do they have iPads? We were able to connect different facilities with grants that could help them acquire the technology they needed for the telemedicine visits. Some places tried different types of mobile iPad stands that would roll to the patient's bedside, and we helped them troubleshoot, how do we position iPads so we can examine a patient in a wheelchair versus in a bed, and what if I need to look at a wound on their back? And how does that work? We help several facilities really take a look at their internet connectivity and where the Wi-Fi blind spots were. Just by trial and error, our faculty found where the good spots were. And maybe if the patient is in that one corner room where the Wi-Fi is not so strong, we could bring them to another private area to do the visits. It took a lot of trial and error. And it's nice to sort of at least begin figuring these things out before you bring the learner in. We had to figure out a system for scheduling for our individual sites, looking at whatever policy they have. Is it a unit manager they would have, or if our group, there's multiple providers that were doing telemedicine visits on several different floors for our own patients, we made a unified schedule that all of us could coordinate on a Google Doc, and so that we don't overlap visits and that we don't overload the nursing staff with too many visits per half day. And it was nice to work out a system about who would review the schedule, who would communicate the schedule to the nursing staff, so it makes sure that we log on in a timely manner. And how do we contact the patients? In addition to scheduling, we had to figure out the system, like, okay, so when we finish with our visit, how are we gonna get orders done? How will we verify the verbal orders, depending on which site you're gonna be doing telemedicine with, or if you're gonna be doing telemedicine with the patients in their homes, to think about how you're gonna get the orders done that are associated with that telemedicine visit, so that when you ask your trainee, what kind of orders do you want to do, you kind of know what avenue you're going to point them towards. And trial several visits before you start teaching. My poor trainees had to just come along for the ride, and we all learned together. I thank them for their patience. So we started with building orientations. We built orientations for our student and resident rotation to tell them, okay, what is telemedicine? How does it apply to our rotations? And what is your role? What can you do during an exam on telemedicine? It's a whole different data set of clinical skills that you sort of have to prepare them for. And as well as, for your own specific practice, after the general orientations for our residents and students, and an orientation for the fellows at the beginning of their fellowship, specific to that rotation, or even my nursing home practice. I would start with an orientation to how I do telemedicine visits, which could be different for how another faculty member runs their visits and what is expected of them in that visit. I always plan with them, it's okay, so during your visit, if you need help, you can always signal to me. You could either chat me or text me or just say, hey, Dr. T, what do you think? So, because some of the nonverbal things while we're standing in the patient room at bedside with the trainee is lost. They can't just turn to us or look at us with questioning eyes during the visit. Give them a chance to establish ahead of time, okay, how do you shout out to me for help? And how can I give feedback if I find that they're getting off track a little bit? So sometimes we would settle on one of our secure text apps. Sometimes we would use the chat on the side of Zoom, for example. Be very careful that it's a direct chat so that the nurses and the patients can't, maybe you would want them to see what you're saying, or maybe you don't want them to see everything you're chatting to each other. But be aware that you have to set it to private if you're only going to make it a two-way between two people. And it might be visible if you make a mistake. How do we communicate to each other the schedules ahead of time as well? I would let them know, I was like, okay, so I'm going to set my telemedicine schedule and my physical visit schedule ahead of time and send you the schedule every morning at 8 o'clock on your email. So they know where the link is, they know which EMR to review for each patient visit, and they know what to expect for the day. I review then what is my typical schedule for the week, and also to set expectations. What I expect them to do in terms of their role in the telemedicine visit, after I model a couple, like Dr. Lubermair says, like see one, do one, while they're having their chance to run the telemedicine visit, I'm going to introduce you. And then after you introduce yourself, I'm going to have you just run the visit the same you would as if you were seeing the patient on your own. I'll be there to chime in if you have questions, or if the patient or family asks something interesting that you're not sure how to fill in. And then I tell them what to expect in terms of discussion, and how they should guide the physical exam as well. So they know what to expect for the whole visit. This is a really good time in your orientation before you jump into the telemedicine visits to emphasize professionalism again. It's very different. We all have experienced the video conferencing fatigue. And now we start to really forget what is it like to actually have to present yourself professionally to a patient. You're my doctor, so I expect them to show up looking at least professional here. And hopefully something professional back here. If you can't do a nice background, the same as if you're standing in the room at their bedside for a regular visit. Please don't be eating or drinking or doing other extracurricular activities during the visit. If you have to excuse yourself for a phone call or a page, say, please excuse me for something, an emergency phone call or page, and it should be an emergency. So I remind them of those things. Discussing the workflow of a telemedicine visit. This is similar to what Dr. Lubermair kind of outlined, how we do our introduction. And to really get them familiarized with who are they seeing on the screen is very disorienting to some of our patients, especially the new admissions that have never met us before. I would have to introduce myself. I'm the doctor in charge and attending physician. This is my trainee, Dr. So-and-so. We're your team today. And we're gonna be asking you questions so we can take care of you. I review with them ahead of time. What are little nuances in telemedicine where you want to refine your history taking skills? You might not be able to ask all the questions. It really helps to pre-round as much as possible so that you narrow down the amount of questions you have to ask them during the visit, and to really go over with them what kind of physical exam you do for your practice on telemedicine. There's so much that we do in geriatrics that require observation that we don't necessarily realize that we're doing. While I'm asking the patients questions, I'm assessing their orientation and their concentration and their language abilities. Be able to observe that and write it down into your note. The patient was focused on the exam. They appear to be hard of hearing. There was no inattention during the interview. Their short-term memory seemed intact. Things like that we can observe for our exam. And how do you guide someone else who's assisting you how to do the physical exam? So like the links that Dr. Lubermair mentioned about different physical exam techniques, I kind of coach them ahead of the visit. It's like, okay, we're gonna look at stomach pain today. Like, what are some things you would ask a nurse to help you examine that? Okay, I'll ask the nurse, what does it sound like? We're gonna ask the nurse to show us the abdomen. Maybe is it distended or something? We're gonna ask the nurse to have the iPad in a place where we can see the patient's face and the abdomen while they press on the stomach, so we can see where she's pressing, but also see the patient's reaction to adjust, to observe tenderness while they examine the stomach. And so if you know what you're going to do the visit for, you can kind of coach them ahead of time. Like, what do they want to guide the nurse through, or the family member or the nursing home staff on how to help you with the physical exam when they're there with a patient? Do we have to think about range of motion exercises if they're talking about a joint, things like that? Or how would you adjust your cognitive testing to do over telemedicine? I like to, again, review with them how to shout out for help, whether there's a raise a hand or send me a chat, and tell them ahead of time that let's discuss this case. For my practice, I found it to be a little bit better to discuss it afterwards, and to kind of check back in with the patient and the nurse later, or check in with the patient and the family on the phone to save the nursing staff time on standing next to the iPad for my practice. But you can decide ahead of time. Just let them know where you're going to discuss the case during the telemedicine visit or after you end it. So they won't feel awkward, like, am I supposed to present to you now, or what's next? Always schedule and prioritize time for teaching. what I learned over this year is that when you do video things, because it took out transit time and waiting for the HPM elevators and walking up and down, we missed out on that time to like staff with each other at the station or in the hallway or at the office. It's very easy to fall into that hole of back to back to back to back scheduling. Or I have a visit all the way up into this meeting, and then you start running out of time at the end of the day to really circle back and do that closing the loop part and identifying the learning issues and reviewing what they did well during the visit and giving feedback after each visit. So schedule time in between or even at the end, whichever works for you, to focus only on teaching during this time. During the visit, it was really fun. It was stressful, but it was such a good experience because all of the staff that we worked with, and especially our trainees, were so game. They were really flexible and they rolled with the punches. We give introductions. I let them introduce themselves. I asked them to please keep your camera on at all times so that we don't have faces appearing and disappearing. Most of my trainees, I would have usually residents or fellows. I would just let them take the lead so that they can practice their skills, asking all these questions and guiding the nurses through the exam. We use the sideline sometimes I would prompt them like, oh, don't forget to examine this part, or help them expand on a question if they miss something in the history. So that it's very hard to, when you forget something, to step back into the patient's room like we normally do on the floor. So if I see that they're forgetting something, I kind of give them a little bit hints on the chat, because it already takes a whole process to schedule one visit for the patient. At the end, I summarize the visit and fill in any gaps and let them know that Dr. Hasebe, for example, and I are going to, discuss your case and talk about what we can do to help you with this problem. I'm going to call the nurse back if we're going to change any medicine or anything like that. If you want, I can call back to summarize with you what we've decided to do. And we're going to be checking in with you whenever I plan on doing the next visit. I found that it was really important, especially during this time, to encourage infection control measures. So you witness what's happening in the nursing home while I was sitting in my kitchen. So I have to tell the nurses constantly, please don't rush. Go ahead and make sure that you take the time to wash your hands or situate the patient, or lower the bed. Go ahead and remove your PPE in the proper order. Don't worry about us. We'll be here, and then we can give you orders. Or I figured out just ways to do it so that I don't see them rushing through whatever it is that could potentially expose them or the patient, so they don't feel pressured for time. And always remember to thank the patient and the staff or the family, because it was challenging for all of us, and they were really learning alongside with us. Sometimes we were lucky enough to catch family members that were on speakerphone during the visit or at FaceTime visits. It's like visit and a visit while they were at bedside. So it was really a group effort. After the visit, so this is after we've excused the nurse and the patient. Most of the times I found it useful with my trainees to say, okay, after the nurse logs off, and say, okay, now let's discuss. Like with Devin here, hi Devin. Like what happened? What did you think was happening? They can review their assessment and plan with me. Then we can talk about the overall telemedicine experience. What are things internally that they found worked well, or some barriers? Oh, I had really difficult time, figuring out how to talk to this patient who was hard of hearing, or maybe external factors. Is like, yeah, it was really bothersome that they were doing the exam in a really noisy place? Or is there a way that we can build the system so that they have a private area that they could bring the patient to? Is there anything in the system that was like an opportunity? Like with our fellows, we're always looking for future QI projects. What could help that nursing home system or your patients' families? What kind of education can we provide to make this run smoothly and safer? For example, one of the projects was to build a template that the nurses could use on the nursing floor to fill in information so that by the time they open the visit, they have all the information they need on one form. And even this year, it's an ongoing project to refine that form and to provide feedback. You did a great job. Good job, Devin. The platform that I utilized the most was Zoom because it was the first platform that was available to us through University Health Partners. And so this is specific to Zoom just because of my own experience, but I really had to think about what the patient is viewing or hearing. It was challenging for the patients with dementia or any kind of visual or hearing deficiencies. It was very confusing to them if the setting was speaker only, because then the familiar face of Dr. T would disappear. And then they would only see the student or the fellow. And then they're like, oh, where did the other one go? And then only when I unmuted myself would my picture pop up on their iPad again. So I found that if that confused them, we tried to make it a gallery view, because with only maybe about 2 people at the visit, along with a nurse who's at the patient's bedside, it was very few squares. So it's not like our big grand rounds or a big meeting. So the gallery view was okay if you're gonna have your faces available for them to see and interact with on the screen at all times. Otherwise, as we were muting or talking, we would disappear on the screen. Also, for the patients that I already knew who are hard of hearing, or even during the visit, if we saw that they were having a hard time hearing the iPad, sometimes the nurses would help them get headphones, but then it would limit how we could communicate with the nurse for exam. And oftentimes, really, oh my gosh, bless their hearts, the nurses will help us translate by saying the same thing that we said a little bit louder to the patient. And that somehow they could hear that better than the iPad because of the limitation of the speakers. There were other patients that I found that were hearing impaired, but really sharp eyes. They could still read what I typed on the iPad. So in Zoom platform, and I'm sure in other teleconferencing platforms as well, there's a capability to do a whiteboard. And so you can pick share screen and then pick whiteboard. And for some of my patients, I was able to type questions to them, the same as I would write on a whiteboard at the bedside for some of my hearing impaired patients to ask them questions. And so we utilize that sometimes. It was nice to know it was there. Like Dr. Lubermair mentioned about her VA visit in Seattle, it's very good to know what your backup plan is. If all of a sudden the iPad rolls into that Wi-Fi blackout area in the corner of the unit, how do we log back on? Or if they run out of battery because they've been doing telemedicine all day, should we reschedule or try to schedule to come in person at a different time, or do a phone visit instead? What would work better? Do not schedule back-to-back visits with other sites. So if you have visits, let's say at Avalon, for example, I had some visits, and then I would see patients at Kuakini Geriatric Care for another part. I realized that having 2 different sites log on too close to each other didn't give leeway for, as always, you want to give the patients time to say what's important to them or to ask questions. Visits would invariably run longer than I expect. And I don't want them to be logging on at the same time. To avoid that, you can schedule them further apart, and you can also set up a waiting room where you have to, as the host, be able to allow them into the meeting or the visit. I think probably for DoxyMe and other platforms, that might not be as much of a problem because it's an individual visit for each one. But even if you're doing it to telemedicine visits where the originating site is a patient's home, you don't want them to be overlapping in some way. In the nursing home setting, we really relied a lot on the nursing staff, and we recognized that it was an added thing for them to do when it was already a stressful time, learning how to deal with all of this infection control measures, how to don and doff PPE properly. While they lived with the fear of exposure to COVID, we were bombarding them with all kinds of new policies, and at the same time asking of them to help us with telemedicine visits. And so we really did our best to try to refine the visits and the scheduling process and the system to be efficient in the use of their time. So for our fellowship program, as well as other sites, I saw that they were really innovative. They provided the nursing staff with templates, worksheets to fill out with information, including vitals. What are things that you're going to ask for during most of your visits that you could guide them to fill out ahead of time before they even log on? I'll show you an example of some of those. And I found that really helped the nurses stay organized, especially if they had to do multiple visits instead of running back and forth or logging into the computer, look at the chart, or finding a paper chart in certain cases. So it was, hopefully it was less stressful for them in that way. I would call ahead of time if I could remember to update the staff on which patients needed vitals, depending on who was able to see the schedule ahead of time, so that they're not rushing to gather vitals as well on the floors. Working with a fellow is really helpful to them to communicate clearly what you need help examining and to say out loud. It was very different telling somebody else, asking them how you're going to do your exam, and to also teach another person how to verbally guide somebody through a physical exam. It's a whole new experience. And so you could practice that with each other or even in person as an orientation. It's like, okay, imagine that this student is your originating site telemedicine helper. How would you guide them through exam of this system? What if your patient fell down? How would you guide this person through an exam of your patient for a visit after a fall? I would ask the nurse how to press on the spine to assess for any tenderness. I would ask the nurse to pan out so I could see the patients, maybe how they're sitting, their posture, how are they moving their extremities. If they are at therapy, it's fine. I would like them to see how they stand up with assistance to see if there's any pain during functional ADLs, things like that. You could easily build that into your teaching experience, something ahead of time. Like, how would you talk them through that? Because the nurses really need help with you clearly communicating. I want you to listen to the heart. Does it sound fast? Are you able to count how many beats per minute? It's hard to really explain what does the murmur sound like? I'm listening to the lungs. You hear crackles. They know how to identify that. And for specific systems. I found for us, it was the most efficient to save the discussion, talking about the assessment plan and the teaching. Let the nurse go and do all that teaching stuff afterward. So they don't have to stand there and wait for you guys to decide what to order. In other instances, maybe they might want to hear that, but maybe family members might be interested to hear what your discussion is if you're doing home visits. But for the nursing home practice, I know that they gotta go. They gotta pass meds and they gotta drop IV to go and talk to some patients or catch some people falling. So we would say, okay, thank you, Cora. I'm gonna miss her. Thank you. We're gonna end this visit now, and we're gonna talk about the patient. And Dr. So-and-so is gonna call you back with the orders. Yeah, and so we would do most of our verbal orders after the visit so that the nurse doesn't have to stand there and wait for us to finish up. This is an example of a couple of pre-rounding worksheets. The left is one that was developed by our fellows that would give kind of like a checklist of what things that they need to kind of check up on so that they have the answers readily available to them. We know that we're going to ask it on a follow-up visit or for recertification, depending on the situation of the telemedicine visit. This is another rounding form about another nursing home. And so there were several examples of this. And by now, at this point, during the pandemic, they had all probably refined these worksheets. So it's a work in progress. And even there's an even snazzier version of this Quakini form that the fellows are working on for their current QI project. So stay tuned. It's really beautiful. So lessons learned, we all learned a whole lot. So in addition to massive infection control measures, I learned a lot about how to be flexible, and we just have to be ready to adapt. By the time we finish one version of our curriculum, there was something else thrown into the fold or some new restriction about where people could go or what we needed to do for telemedicine. So we were always checking up on what needs to be learned and how to teach it to our trainees. Scheduling everywhere, scheduling teaching time, scheduling clinical visits, and scheduling telemedicine visits was a challenge, and it was unpredictable depending on staffing availability, when we had to move different kind of teaching times. So I just did my best to keep a flexible schedule as much as possible. Every patient responds differently to telemedicine. And so, yeah, so a lot of the evidence will say there was a positive response to telemedicine, but, for just like, any patient's response to anything you do in medicine, you really got to focus on what works for them. There were a handful of patients that just could not do well with telemedicine. And if possible, I would round after hours to visit them in person if needed, if that's what they needed. The same for learners. If you see that they're starting to burn out or disconnect, what can you do to meet in person for some kind of teaching or have them connect with patients in another way as much as possible? It's not 100% guaranteed to work for everyone. Share resources, call us. We love to share resources all the time. And I share helpful websites and YouTube videos like the ones that Dr. Lubermair mentioned with our trainees. And just like Dr. Masaki, I always remind her, schedule time for breaks as well. Don't do meetings back to back to back to back and then realize that your bladder is gonna explode at the end of the day, or that you haven't eaten lunch and it's 3 o'clock. Because when you start to do everything remotely, it's so easy to overbook yourself even more than we were doing in person. And so I really had to think hard about spacing things out. And here's our resources. We're going to have this available to you as a handout that you can click on so you can watch all those videos and check out those websites. And we, in addition to Dr. Lee Jabsum and the CARES Project staff, we really want to thank all of our patients, the nursing home staff that helped us through it, the home care teams, and most of all our trainees for just being so flexible and eager to learn no matter what the circumstance was. They made it doable. They really made it possible for us to continue this. And that's it. Thank you.
You're muted.
Thank you, Dr. Lubimir and Dr. Takenaka. for a very interesting and informative presentation. We are a little bit over time, but our audience is stuck with us. Does anybody have any questions for either of our speakers today? I don't see any questions. Well, thank you both for an interesting talk as well as the resources. Everyone, it will be posted on our website, the video, and also the resources will be posted in case you need to get to them. Please don't forget to fill out the evaluation. The link was put in by Julie into the chat box. So please don't forget to do that to get your CME credits. Okay, thank you all so much. See you next time. Happy holidays.